Good afternoon, everyone, and welcome to today's webinar. My name is Michaela Holm. I work with Kaufman and Associates, and I'll be your moderator for today. Before we begin, I'd like to highlight the main features of the Zoom webinar interface. First, the presentation slides are the main window, and the speakers will appear at the top just above the presentation. At the bottom of your screen is the Zoom menu bar. Here you'll find the Q&A box. We encourage you to use this feature to submit any questions at any point during the webinar. We'll leave time for Q&A segment to address all questions at the end of the presentation. At the bottom of your menu bar, you'll also find a chat box. Please use the chat box to report any technical issues you may be experiencing. We'll respond to those concerns as they come in. Another menu option is raise hand icon. Please use this feature when you'd like for us to unmute your line to ask questions out loud during the Q&A segment. Additionally, live captioning is available during today's broadcast. Simply click the CC icon from the bottom of your menu bar to use this feature. And then finally, please be aware that today's webinar is being recorded and that the recording will be made available online in the near future on go.cms.gov/AIAN. And at this time, I'll turn it over to Dr. Susan Carroll.
Thank you. And good afternoon, everyone. Hi, it's Dr. Susan Carroll. I'm the CMO for the CMS Division of Tribal Affairs, and I welcome you to today's All Tribes webinar on an interim final rule with comment that was issued on November 4th. Consistent with CMS's tribal consultation policy, the purpose of this All Tribes webinar is to provide an overview of the interim final rule and hear comments and to answer any questions that tribes might have. Please remember that for comments to be considered, written comments must be submitted pursuant to the requirements published in the Federal Register. We are pleased to be joined on this call by our CMS colleagues. Dr. Lee Fleischer, who is the Director of the Center for Clinical Standards and Quality, also known as CCSQ, and joining him are other staff from CCSQ, Lisa Parker, Lauren Oviatt, Adam Richards, David Wright, and Karen Tritz. At this point, I'd like to turn the call over to Dr. Fleischer. Lee, over to you.
Great, and thank you everyone for joining us this afternoon and for inviting us to this call to discuss the CMS Omnibus COVID-19 Healthcare Staff Vaccination Rule. We recognize that the requirements may not directly affect you, but it could affect the healthcare facilities within your purview. I want to start by acknowledging that patient safety is the foremost priority of CMS. This regulation and the requirements within promotes a system-wide approach to protecting anyone seeking care by ensuring that the healthcare staff are vaccinated for COVID-19. I also note that the CMS rule was coordinated and aligned with several of the other vaccination requirements you've seen recently. Importantly, I'll talk more about this momentarily, is that the facilities regulated by CMS should look to our rule first. Finally, we want to make sure that everyone understands the rules prior to some of the key deadlines we'll discuss shortly. That's why we're taking the opportunity to speak with you all directly today and look forward to the dialogue at the end of this formal presentation and continued dialogue thereafter. Next slide. So, already gave my opening remarks. We'll go over the eligibility, the basic requirements, our approach to enforcement. I mentioned the interaction with other regulations and requirements and actions to take, and then a Q&A time period. So on the next slide, we'll start with the eligibility. Who is included? The staff vaccination requirements apply to the Medicare and Medicaid certified facilities that are regulated under the foundational Medicare health and safety standards known as the conditions of participation or the COPs, the conditions for coverage or the requirements for participation. The COPs, the conditions for coverage and the requirements for participation were established by CMS to protect individuals receiving healthcare services from Medicare and Medicaid certified facilities. As we've discussed to this point, patient safety is a fundamental principle to this regulation, and protecting individuals from COVID-19 across a variety of settings is the most important factor. The COPs help us ensure those protections. And if the facilities want to participate in Medicare or Medicaid programs, they must abide by the COPs. We've included 15 provider types. You see them here, ranging from hospitals to hospices, critical access hospitals, home health agencies, and I'll let you read through the entire list. There are certain certified providers and supplier types that are not included in staff vaccination requirements, including religious, non-medical healthcare institutions, organ procurement organizations, and portable X-ray suppliers. For OPOs and portable X-ray suppliers, both of these entities likely have staff who are indirectly included in this vaccination requirement through service arrangements with applicable facilities. FQHCs that do not participate in Medicare are also not covered by these requirements. These facilities are sometimes called Medicaid-only FQHCs. Additionally, CMS's statutory authority does not extend to certain other types of facilities. And if we can go to the next slide, like assisted living facilities, group homes, and physicians' offices. Again, these requirements only apply to facilities regulated under the COPs. This is a key element to remember when determining whether the staff vaccination requirements apply to a given facility. We'll talk about staff who may work between settings and our expectations based upon the regulation momentarily. While I've mentioned that our authority does not extend to assisted living and group homes, I'll also note, given the interest on the line, that entities like Medicaid home care services, home and community-based services, and schools receiving Medicaid funding are not included in this regulation, as we do not regulate these under the conditions of participation. Next slide. There are three basic facility requirements that facilities must complete. First, they must have a process or plan for vaccinating all eligible staff. That is to say, those who do not qualify for a medical or religious exemption or are considered full-time teleworkers, which we'll discuss shortly. Number two, they must have a process or plan for providing exemptions and accommodations for those who are exempt. Accommodations could include, but are not limited to, testing, source control, physical distancing, and others that I'll discuss later. And they must provide a process or plan for tracking and documenting staff vaccinations. Next slide. Now, the regulation establishes two important phases. Phase one requires that within 30 days after the regulation is published, or as you see by December 6, 2021, facilities have all processes and plans in place for vaccinating staff, providing exemptions, and tracking staff vaccinations. It also requires that the staff at all healthcare facilities included within the regulation must have received, at a minimum, the first dose of the primary series or a single dose of the COVID-19 vaccine prior to staff providing any care, treatment, or other services for the facility and/or its patients. Phase two requires that within 60 days after the regulation is published, or January 4th, 2022, staff must have received the shots needed to be fully vaccinated. With the exception of those who have been granted exemptions from the COVID-19 vaccine, or those staff for whom the COVID vaccine must be temporarily delayed as recommended by the CDC. We believe that the 30 and 60-day timeframes are reasonable and allow for the facilities to implement the staff vaccination plans while expeditiously getting healthcare staff vaccinated as quickly as possible. Next slide. The WHO. The vaccination requirements apply to all eligible current and new staff. Again, those who are not exempted are full-time teleworkers working at the facility, regardless of whether they have direct or indirect patient care. You see the list on the slide. The basic rule of thumb is that any staff member who is on site at a facility included in this requirement, who could possibly interact with others who provide direct care, must be fully vaccinated. This includes individuals who are on site full-time, staff who move between facilities. For example, a nurse who shifts between a nursing home and an assisted living facility and may have interactions with others who may provide that direct patient care in one of our regulated facilities. And individuals who may be on-site part-time, but who have full-time responsibilities in a facility not regulated by CMS. For an example, an independent physician with privileges in a hospital who is admitting or treating patients on-site. The physician's office is not regulated, but being on-site at a facility included in this regulation means the physician must be vaccinated. Importantly, we consider fully vaccinated when it has been 2 weeks or more since they have completed a primary vaccination series for COVID-19. We do note that staff who have received all shots by the January 4th deadline, that phase 2, are considered to have met all the requirements, even if they had not yet completed the 14-day waiting period required for full vaccination. Next slide. Now, a primary vaccination series, of course, is consistent of the single dose Janssen or Johnson & Johnson COVID-19 vaccine, one of the multi-dose vaccines, either the Pfizer COVID-19 or the Moderna COVID-19, or a vaccine regimen listed by the World Health Organization for emergency use in accordance with the CDC guidelines. At this time, we are not requiring staff to receive additional doses beyond the primary vaccination series or boosters considered to be fully vaccinated. But as I'm sure you're hearing, the CDC does recommend those additional doses. Next slide. Now, how do the exemptions work? And CMS requires facilities to allow both for medical and religious exemptions in accordance with federal law. Facilities must have a process or plan in place that permits staff to request either a medical or religious exemption. This is one element that the surveyors will seek to review. There are specific requirements as it pertains to what level of documentation, you see this on the slide, that is needed for either a medical or religious exemption. Facilities should review the Equal Employment Opportunity Commission's compliance manual on religious discrimination for more information on religious exemptions. We want to be very clear that we are requiring facilities to have a process for handling vaccination exemption requests for staff as required under federal law, including medical conditions for what the vaccine is contraindicated or other reasons like sincerely held religious beliefs. However, providers and suppliers are not required to grant exemptions to staff who are not eligible, and no exemption should be provided to staff who are simply trying to avoid vaccination. Additionally, staff who have previously had COVID-19 are not exempt from these vaccination requirements. Available evidence indicates that COVID vaccine offer better protection than natural immunity alone, and that vaccines, even after prior infection, help prevent reinfection. CDC recommends that all people are vaccinated, regardless of their history of symptomatic or asymptomatic SARS-CoV-2 infection. Next slide. Now, this regulation requires that facilities develop a process for implementing additional precautions for any staff who are not vaccinated in order to mitigate the transmission and spread of COVID-19. For those staff who are exempt, facilities should provide accommodations, which could include, but is not limited to, testing, physical distancing, source control, or assigning unvaccinated individuals to non-patient care areas with low risk to patients. This is ultimately up to the facility to decide how best to handle. In all cases, facilities must ensure that they minimize the risk of transmission of COVID-19 to at-risk individuals. Next slide. There are a few other important elements. Number one, vaccination is the only option. This regulation does not allow for testing as an option or an alternative to vaccinations. And there are currently no new reporting requirements. CMS expects facilities, specifically hospitals and nursing homes, to continue complying with facility-specific data reporting requirements set forth in our emergency regulations issued by CMS in May 2020, August 2020, and May 2021, respectively. Additionally, facilities participating in several of our inpatient or outpatient quality reporting programs must collect data on the new COVID-19 vaccination coverage among healthcare professionals measured quarterly, with the first collection period for many of these programs beginning on October 1st, 2021, and running to December 31st, 2021. Next slide. CMS has established survey and enforcement process that it will use to ensure compliance with the staff vaccination requirements. Checks for compliance with the requirements will be conducted by the state survey agencies during two periods: recertification surveys and complaint surveys. While on site, surveyors will review the facility's COVID-19 vaccination policies and procedures. That is to say, the plan for vaccinating eligible staff, providing exemptions, and tracking staff vaccination, the number of residents and staff COVID-19 cases over the last 4 weeks, and a list of all staff and their vaccination status. This information, in addition to interviews and observations, will be used to determine the compliance of provider or supplier with these requirements. Finally, the accrediting organizations will be required to update their survey processes to assess facilities they accredit for compliance with vaccination regulations. Next slide. Providers out of compliance will be cited based upon the level or severity of non-compliance, with an opportunity to return to substantial compliance. For example, for hospitals, there's immediate jeopardy, the most severe and indicative of serious non-compliance, which would lead to termination within 23 days if the deficiency is not resolved. Condition or substantial non-compliance, and standard, which is the least severe and indicative of minor non-compliance. CMS has a variety of established enforcement remedies. For nursing homes, home health agencies, and hospices beginning in 2022. This includes civil monetary penalties, denial of payment, and even termination for Medicare and Medicaid programs as a final measure. The remedy for noncompliance among hospitals and certain other acute and continuing care providers is termination. It is not our goal to terminate facilities from the Medicare and Medicaid program. In fact, we want to work with facilities to bring them back into compliance as quickly as possible so that every person benefits from safe and quality care. Termination is the absolute last resort, and after all the other levers have been exhausted. It's important to note, however, that we will not hesitate to use our full enforcement authority to protect the health and safety of patients where requirements are necessary. Finally, next slide. CMS recognizes that there are several vaccination-related requirements for healthcare workers. So we've established a hierarchy by which to follow. Healthcare facilities are generally subject to new federal requirements based upon primacy. If the facility is Medicare or Medicaid certified and subject to the CMS conditions of participation, they should adhere to the requirements outlined in the CMS Omnibus COVID-19 Healthcare Staff Vaccination Regulation. The CMS takes priority above other federal vaccination requirement, and CMS's oversight and enforcement will exclusively monitor and address compliance for provisions outlined in this regulation. There are rare situations where the executive order ensuring adequate COVID safety protocols for federal contractors or the OSHA COVID-19 Healthcare Emergency Temporary Standard may also apply to staff who are not subject to the vaccination requirements outlined in the CMS Omnibus Staff Vaccination Rule. Facilities should review these regulations and comply with any other federal requirements as necessary. Finally, we have received many questions on the interaction of this regulation with other laws. The bottom line is this regulation preempts state and local laws and/or state-issued executive orders under the Supremacy Clause of the United States. Next slide. So the actions to take is reviewing the regulations and the specific sections applicable to your facility. Review the frequently asked questions document, and we'll be updating that frequently over the next several weeks with regard to the specifics of this regulation on the CMS emergencies page. And for those in whom our COPs are applicable, develop your process or plan for vaccinating staff, providing exemptions and accommodations, and documenting and tracking staff vaccinations. And we do note those two milestones. So for those of you in healthcare, and I practiced just last Friday in a facility providing anesthesia, I know what it's been like for the last 18 months and how hard people have worked to take care of the individuals we serve. But we at CMS believe that it is important to utilize these safety and health regulations to protect our patients. And we believe strongly that vaccination is the best way to do that. And with that, I will turn it over to questions and back to Susan.
Thank you, Lee. What a very thorough presentation. And at this time, we'd like to open the call up for any questions or comments. We will review the questions that have been submitted already through the Q&A box, and we will also open up the call for any comments and questions now. Michaela or Tom, can you assist us here?
Yes, I will assist with the questions. If everyone could please place your questions in the Q&A box located at the bottom of your screen, or use the raised hand icon to unmute, and we can unmute your line. I'll move forward with reading the questions that are already in the Q&A box. The first question is, under EO 13175, agencies must consult with tribal officials before developing regulations that have tribal impacts. To enforce this rule against tribes prior to meaningful consultation is a violation of the EO. When will you be holding consultations?
Okay, is Lisa Parker on the line? I mean, part of this is that we are now in, Lisa, do you have comments first?
No, I am on the line, but I would defer that question to Dr. Carroll or to Kitty.
Thank you.
Sure, and this is Kitty Marks, and I'd welcome Dr. Carroll's input as well. Pursuant to our CMS tribal consultation policy, we do try to conduct tribal consultation prior to promulgation of rules. That is not always possible, so that's why we hold the all tribes calls to hear your concerns and questions you have, but also as part of our CMS tribal consultation policy, comments should be submitted consistent with the requirements in the Federal Register. I did see some other questions about whether this rule could be put on hold for tribes until further consultation. We'll have to take that back to our general counsel. But this is our process currently under CMS, is to hold these all tribes calls, listen to your comments, and then submit comments through the Federal Register. So Dr. Carroll, do you have anything else to add there?
You're still on mute.
Just to agree with you, Kitty, this is the process that CMS utilizes. We have this call today as a form of consultation and ask that you ask the questions, submit your comments back to CMS so that we can then move the rule forward as needed. Thank you.
Right. And consistent also with our consultation policy, tribes can invoke additional consultation with the agency at any time. So we'll follow back up on this question. Just real quickly, there was a question about whether slides will be available for distribution, and I defer to Lee on that question, but there are a couple questions as to that point. So
I believe, and Adam's on, that the slide sets are already up and available.
they have been distributed publicly. Correct.
That's correct.
Okay. Very good. We'll send out the link. So, okay, thank you.
The next question is, will the employee be prohibited to coming from work until the 2 weeks expire after the last dosage, even though they had complied with the January 4th deadline?
No, in fact, we state that they can come into work. They should take precautions with regard to transmittal to patients. That's always the highest priority. But we recognize that the facility itself must decide based upon its own needs what those policies and procedures would be. And Lisa, feel free if you want to articulate further.
Well, yeah, I would just add that in accordance with the regulation, an employee could begin providing care or services at the facility after their first dose. And then they would be considered fully vaccinated for purposes of the regulation once they receive their second shot of a 2-dose series.
Thank you. The next question is, so is there no mandate?
I'm not exactly sure what that is meant to mean. The vaccine, it is vaccine requirement, but the way that CMS works is through our conditions of participation. So it's a requirement for facilities to develop plans to vaccinate all individuals or provide exemptions. Any further clarification, Lisa?
No, I think that's it.
Right. That is the approach that CMS takes is through our conditions of participation.
The next question is, The title of Civil Rights Act exempts tribes and thus tribal entities from its requirements. Is the source of law that requires religious exemption. Since this does not apply to tribes, the CMS agree that tribes may choose whether or not to provide an exemption based on religious objections.
I would defer to Lisa, or we may have to take that back for.
I would say that the regulation indicates that facilities can have flexibility to set up the process for religious exemptions. We do not set forth criteria for how those religious exemptions should be adjudicated or evaluated. We do refer providers to EEOC resources in the regulation. However, we could take this back to our general counsel for some additional information.
The next question is, the presentation of inclusion of tribes should have been more clear to only include tribes under IHS questions in the FAQ is not sufficient practice. President Biden Executive Order 14042 regarding the vaccine mandate for federal contracts explicitly exempts tribes.
So to be clear, what we're talking about today is facilities, not individuals, facilities that are regulated under the conditions of participation by CMS, which is separate from the president's executive order. Lisa, any further comments?
I would just add that to the extent an IHS facility or a tribal facility complies with the conditions of participation, then we believe that these requirements would apply.
Next question is, would tribal leadership be required to be vaccinated in order to tour the tribe's FQHC?
Lisa, I'll defer this one to you.
I believe that the answer to that would be yes, to the extent that the goal of the regulation is to reduce transmission of COVID-19. So if members of tribal leadership are similar to a governing body or board directors, if they enter the facility in order to carry out their leadership responsibilities or interact in person with staff who enter the facility, then yes, the vaccination requirements would apply.
CMS Rule, page 61556 states, most of these 21 COPS providers and suppliers are regulated by the Interim Final Rule. Thus, the rule does not apply to all providers regulated by COPS. The rule also explicitly states its application is limited only to providers on the list. Indian healthcare providers, IHCPS, are not listed. Is it CMS position, therefore, that unless the IHCP fits within one of the provider types listed, this rule does not apply to IHCPS?
This rule applies to the facilities we regulate, so that is an accurate statement, or people who are associated. And I'm not exactly familiar with that type of facility, so maybe if Dr. Carroll or Kitty can help me understand that issue. But for example, we know physicians' offices, it would only be the physicians who have medical privileges and work in hospitals, but not the rest of the office. So Dr. Carroll or Kitty.
Surely, Carol, for Indian healthcare providers, these are the facilities that the Indian health system uses to provide healthcare. That may be hospitals, CAUS, clinics, etc. And they would be under this regulation as they are being certified and have to meet the conditions of participation. Thanks.
Thank you.
If a tribe provides behavioral and mental health services, but does not meet all requirements of CFR and 410.2 definitions for a community mental health center, do the requirements apply? For example, a program with which provides outpatient mental health services, has a FHQC billing agreement and is licensed by the state, is such a program subject to the requirements, or is this an FHQC Medicaid only type program, which would not fall under the regulation?
Lisa?
Yeah, I'll try that one. So I can say that a Medicaid only FQHC would not be subject to these requirements. With regard to other provider types and whether the requirements apply, the bottom line is that if the provider is a Medicare certified provider to the extent that they have a CMS certification number, or that they know that they follow the COPs and that they're surveyed at some point, that's the beginning of the analysis to determine whether the requirements applies if the provider is subject to the conditions of participation on a regular basis. So for Medicaid only FQHCs, these requirements do not apply to those facilities.
Please provide more details about how to determine whether an employee meets an exemption. What are examples of instances in which employees have successfully met the requirements for an exemption? If tribes have questions, will CMS open on whether an exemption is met in a specific circumstance?
So we are allowing the facilities themselves to set up a process to determine exemptions. We do have documentation requirements that are outlined in the rule itself. We do point to the Equal Employment Opportunities website with regard to some of the issues with respect to religious exemptions and the medical exemptions. Again, there's documentations, but we have not opined on the process by which an individual facility makes that determination. We will survey with respect to meeting those COPs. Lisa, any additional comments?
No, that's accurate.
We have signed up to bill Medicare. However, we have not started to bill yet. Does this still apply to us?
The question is really not whether or not somebody bills Medicare, it's whether or not they're a certified Medicare or Medicaid provider type. So that's really the question. And if it's a facility, have they done that?
Will CMS recognize that enforcing this rule against tribes prior to meaningful consultation is a violation of EO 13175? OSHA recognized this and stated that they would extend deadlines for tribes for after consultation.
I cannot comment on that at this time. We will bring that question back to CMS.
Tribes are exempt from the definition of employer in Title VII of the Civil Rights Act and ADA. How is CMS going to ensure that accrediting organizations know that tribes are not required to provide religious and disability exemption?
Lisa or David, any comments on that one?
No, and I would defer to Dr. Carroll if there are specific requirements regarding tribes and religious exemptions. Otherwise, we can take that question back.
Lisa, I think that it would be good to bring it back to OGC.
We thank you for the question. We will capture all of these questions and take them back to CMS and the General Counsel's office so that they're aware of your concerns.
Does this apply to tribal ambulance services that bill for Medicare and Medicaid?
I know, Lisa, we've answered this specific question, so I'll defer for the specifics to you.
Sure, it was ambulance services.
Correct.
Okay, so an ambulance provider is not a CMS certified, Medicare certified provider. So in general, the answer is no, that the requirements would not apply to those types of providers. However, if an ambulance or EMS service provider has a contractual relationship or other arrangement with a provider, then to the extent that they provide services and treatment to individuals in the service in a certified provider, then yes, the provisions would apply. So for example, if a hospital has a contract with an EMS provider, then those EMS workers would need to be vaccinated. Or if a long-term care facility, for example, has a contract for non-emergency transportation with an EMS company, then those individuals would also need to be vaccinated. So it's dependent on the either a contractual agreement or having another arrangement with a certified provider.
If non-clinic employees are not necessary to be vaccinated, the rule, I believe, extends to cover anyone employee who comes in contact with any employee performing duties at the clinic. How do you reconcile to the two?
And this is really about the facility. So clinics, depending on the clinic, if it's not a Medicare certified and or Medicaid certified facility under the COPs, then only the individuals who would work in one of those facilities are covered. Just want to make sure with Dr. Carroll or Lisa that I may be misinterpreting the question. If there's anything else that is relevant.
I would just add for clarity that the regulations do apply to non-clinical employees who work in a certified facility. So for example, intake workers at a hospital would need to be vaccinated.
I don't have anything else to add.
Lauren, I see your hands raised. Do you have anything to add?
Yes, I do. There was a question that has been answered in the Q&A that's related to this, and there were a couple questions I saw pending about this. That it seems that many tribes have buildings where the clinic is in one part of the building, and there are other tribal-related business functions within the same building. As long as the people working in the other parts of the building are not providing services or working in the clinics, they're not subject to these requirements. Only those people working in and for the certified clinics are subject to the requirements. Just being in the same building does not establish a requirement. We would expect, appropriate, just, not hanging out in the clinic, on your lunch break or things like that, appropriate infection control and separation.
Thank you. The next question is eligibility. Who is included? If your facility is not on the list, does the regulation apply to your facility? In Washington state, most tribal clinics are outpatient primary care clinics. This type of clinic is not on the list. Can you please confirm the tribal primary care clinics are exempt?
As we stated during the presentation, if the facility is an outpatient facility, very similar to a doctor's office, it is not regulated under COPs and there does not fall under the COPs. If any of the clinicians in the clinic go into a regulated facility because they have admitting privileges and see patients and they're part of the medical staff, those are the only individuals within those clinics that would fall under the COPs.
Since tribal healthcare facilities that operate under an ISD-EAA compact contract were not specifically included, and since the rule says it does not directly apply to other healthcare entities, how does it apply to our tribal health center operating under a 638 contract?
Okay, Lisa or Dr. Carroll,
It is my understanding that this regulation impacts facilities that bill Medicare and Medicaid, that have CNN numbers. Therefore, those health centers, if they are subject to Medicare and Medicaid rules and this regulation, they would be required to fulfill this regulation.
But just billing Medicare or Medicaid alone does not mean they're included in this regulation. It's whether or not they're certified by Medicare and Medicaid.
The next question is, the state does not have a role in regulating tribal health facilities. We are concerned that the IFR grant a role to the state to involve themselves in tribal health operations on the vaccine mandate. What are CMS intentions here, and will the IHS tribal facilities instead be engaging either directly with CMS or with our accreditation organizations as applicable?
Yeah, I see David Wright turned on his camera. Would you like to respond?
Yeah, thanks, Lee. So for this, it doesn't create a new oversight. Certified facilities became certified as a result of a compliance visit, either by the state, by a federal survey team, or by an accrediting organization. And that's primarily who will continue to review and oversee compliance with this requirement as well. So there's not a new oversight that will be occurring. If you're a certified provider, whoever has been doing those compliance certification visits for you will continue to do so. And this will be an additional element that they're looking for compliance with.
Thank you, David.
The next question is, what about HIPAA requirements? How do those apply for record keeping?
Lisa? I don't know if you,
So a hospital would need to ensure that documentation submitted regarding the vaccination status of employees is maintained in accordance with HIPAA and other requirements.
"22 states have challenged the CMS rule. Keeping OSHA's rule was stopped. What are your comments on this litigation?"
we have no comments at this time.
"Will sites that are not CMS certified but do bill and receive payments from CMS be required to comply with the mandate?"
I think that's been answered, that they need to be CMS certified, and I will move to another site. Can you hear the buzzing? Dr. Carol, Lisa, or I'm clear? Okay, very good. Thank you.
Patients' safety is mentioned several times as a rollout of the mandate, and I agree. However, we will be terminating providers and patients will not be getting preventative care that is pertinent to overall health. There is an equivalent amount of danger to our patients who will not receive care as per transmission of COVID. Stats on FQHC transmitting COVID are not available as we take precautionary process against the transmission.
Sure, and I'll ask David Wright or Karen Tritz to follow up on this, but there's two things. Number one is our hope is to not terminate any providers. Our goal is to get providers back into compliance through our survey and enforcement process. So that was stated, and I'll state it again. That is the goal. We have seen overall that, again, just today, more and more data to say that hopefully this will minimize the amount of quarantines and that individuals in the end will receive safer care. But David, any comments about the survey and enforcement process and compliance issues?
Yeah, thanks, Lee. Just in general, as we do with our oversight and enforcement for all the health and safety requirements, including this one, all entities have an opportunity to demonstrate compliance. And if they do not demonstrate compliance, have an opportunity to submit corrective actions in time to be able to come into compliance. And so that's our expectation with this requirement as well.
The next question is, what if someone has an adverse effect to the vaccine who is held responsible for this and must pay compensation or facilitate pay?
Lisa, does the rule, I think the rule is silent about this factor, but I will.
That's
answer
correct.
The facilities develop the processes and plans.
Are there whistleblower provisions? Also, what happens if there is a vaccination shortage? Can a new employee be hired if they received their second and final shot on January 3rd? And can they report to work if highly mitigated? How are surveys conducted? Will there be notifications or surprise visits? Thank you.
Yeah, I'm going to ask David to comment some more on the surveys or Karen Tritz. And again, the goal is to take care of the patients. So with the appropriate mitigation, our plan is that they should be working and providing care with appropriate safeguards. And David, can you comment about the documentation they would just need to, if there's truly a vaccination shortage in that area?
Correct. So what we would, as we have with other requirements for vaccination, for example, for nursing home residents, if a facility or an area is unable to meet the needs for their staff, they can document that, and we will consider that to be compliant as long as they're making a good faith effort to secure vaccination for their staff.
And David, can you just briefly comment on whether these will be surprise surveys, or how will that be handled?
All of our surveys, anyone who is certified by Medicare and Medicaid has received an unannounced and would continue to receive unannounced surveys for compliance. All of our surveys are unannounced.
Thank you.
And the next question will not answer. The United States government made the decision to implement this.
The next question is, there is no clear definition on what applies for religious exemption. The documents that you refer us to are also unclear. It feels like we are being asked to have our plan make theological decisions without any guidelines. If we do not grant a religious exemption, it feels as though we're putting our facility at risk or at litigation with those individuals. If we're being asked to implement this and being held responsible for these decisions, how will this be measured when we are evaluated?
So again, we have asked that you implement a plan or a process, and that's what we will survey against. Mandates have been implemented in multiple healthcare facilities with great success throughout the country. But I will defer to Lisa on specifics in the regulation.
No, I think you said it. We don't give any specifics at this time. I would encourage you to submit that as a public comment, because we will be examining the public comments that we receive on the rule. And then with regard to how we will evaluate the religious exemptions, as Dr. Fleischer mentioned, we will be looking for a process, ensuring that that is in place and applied consistently when evaluating exemptions. And I don't know if David wanted to add anything else regarding the survey of the religious exemptions process.
Yeah, I think you touched on it, Lisa, and that is we're looking to make sure there's a process that's consistently applied and that the facility is aware of who has received exemptions and who hasn't, and other aspects of their vaccination status.
I see deadlines for vaccinations, but when might this interim rule end? Also, though someone has been vaccinated, boosters are now recommended. How long and how often must healthcare workers continue to get vaccinated to stay in compliance with CMS?
Lisa, do you want to comment on the way the interim final rule is laid out?
Sure. Interim final rules are generally effective for 3 years after their publication if they are not finalized. And so if we finalize the rule, then it will be effective in perpetuity or until we make additional regulatory changes.
And at this
Mhm.
time, the only requirement is to get the primary series.
Yes, that's correct. The rule doesn't require boosters at this time.
The next question is, since tribes are exempt from the definition of our employer under Title VII of the Civil Rights Act and the ADA, will CMS consider amending the IFR to reflect that accrediting organizations should be aware that tribes are not required to provide exemptions under these authorities, particularly religious exemptions?
I think when, go ahead.
No, I was going to say, I think we addressed that already and said that we
Okay.
would need to take that back.
Correct.
The next question is, for clarification, Title VII of the Civil Rights exempts
Yeah, I think
tribes
we've
as
addressed
employers.
that
Is
and
one-
we'll
is that
also
one
take
too?
it back. Thank you.
Will sites that are not CMS certified but do bill and receive payments from CMS be required to comply with the mandate?
I lost.
I think,
And I think we've already answered this one.
Yeah.
So,
Okay.
yeah. Go on,
Are
Michaela.
there any sample plans and guidelines for a tribe to use as a guide in implementing this mandate?
Our hope is over the next several months to, or shorter, to have sort of, CMS will not publish specific plans, but through the QIO program, we hope you can get assistance with best practices from other either tribes or other facilities in your area.
Next question is, Dr. Carroll's statement that the rule applies to tribal clinics seems to be contradictory to the language on page 61556 that explicitly states the rule applies only to COP providers listed. Do you plan to confirm this position with tribes in writing or perhaps further research?
Refer to Dr. Carroll.
Can you repeat the question? I don't see it up in front of me, so I'm trying to understand.
Yes, it was from Heather Erb.
see
It's
it,
Dr.
okay.
Carroll's statement that the rule applies to tribal clinics seems to be contradictory to the language on page 61556 that explicitly states the rule applies only to COP providers listed. Do you plan to confirm this position with tribes in writing or perhaps research this further?
I will need to research this further. However, my understanding is if a tribal clinic is only a Medicaid provider, then they are not being held to this rule. If the tribal clinic is associated with a tribal hospital that is under the regulation, then that clinic would be responsible to adhere to the regulation. And I'm happy to take more questions on that later, but I think we've covered the tribal clinics. But if you're provider based, you do have to adhere to the rule.
Are all FQHCs covered even if they are only outpatient clinics, assuming that they are not Medicaid only FQHCs?
Lisa, any comment?
that, I think that's really pretty much the same question that Dr. Carroll just answered. And so,
Okay.
Yeah.
We have developed a form for employees requesting religious exemptions based on strong rejection based on religious objection, but have required wearing N95 at all time at work and agreeing to COVID testing on a weekly basis. Does this satisfy the requirement?
We can't on this call categorically state one way or the other, but if you have a process in place that you feel provides appropriate safeguards to your patients, then that is consistent with the requirements in the regulation. David, any other comments?
No, Lee, I think that's correct. Again, we're looking for a practice and mitigation that's consistently applied and that is monitored by the facility.
One second, I am reviewing some of the questions. The next question is, are the mandates invoking the supremacy clause of the US Constitution? If so, tribes are not subject to the supremacy clause.
We will also take that back to the Department of Justice. So thank you for the question.
The next question is, from the information provided so far, it is very difficult for tribal facilities to know whether the rule applies to their facility. Can you please provide clear direction on how tribal facilities can verify whether they are subject to this rule? Who can be contacted to confirm whether a facility is subject to the rule, or whether can a tribal facility look up this information?
Yeah, Lee, I can take that. I've been sharing in the answers a website that we maintain. It's not the best website in the world, but it's called QCOR, QCOR. Again, I've put it in the answers so we can share it more widely, but on that website, we do list all of the certified provider and supplier types. You can go down to the one that meets your definition in terms of your operations, if you're a nursing home or an ambulatory surgical center or others, and select that provider type. When you select that provider type, it'll give you the option for provider lookup, and you can put in your information there and see if you're certified or not. Part of what we're telling people is if you don't know that you're certified, you probably aren't, because in order to be certified, you've gone through an enrollment process as well as usually a survey, which means an on-site inspection by an accrediting organization or by, again, the state or federal survey team. You're subject to on-site complaint investigations. So you've received some direct engagement with people as a result of what you're certified as. But again, you can at least go to that website and check. I see some people are clicking on the first link, which is for laboratories. If you go farther down on the left-hand side, you'll see the other provider types that may be more relevant to your operations.
And David, why don't you comment? I've seen a couple of questions. CLIA certified is very different than Medicare or Medicaid certified provider for the purposes of this regulation, but please feel free to expand.
Sure. CLIA is the Clinical Laboratory Improvements Act. It's the certificate that's required for any entity that's going to do human testing of samples within the United States. It's separate and distinct from Medicare certification. So you can be CLIA certified, but not receive or even be eligible to receive Medicare reimbursement. The CLIA and the CLIA labs specifically are not covered under this authority. However, many CLIA labs are located within entities that are. So the staff for a hospital lab, for example, are going to be operating under a CLIA certificate within that hospital, but because of their employment by the hospital, would be subject to the requirements under the IFC. So, but CLIA itself doesn't have a requirement for vaccination. It's all covered under the COPs, as Lisa and Lee have been discussing.
The next question is, when you say you'll take some of these questions back to CMS, when and how will we receive the answers or responses?
Dr. Carroll, how
Well,
would you like?
I was going to look to Lisa to say, in an interim final rule with comment, the agency takes the comments and reviews, and then a final rule, if I'm understanding correctly, will be processed at some point next year.
Well, let me just respond like this. So with regard to the questions, particularly, I think, related to the special circumstances of tribes, we do have a public Q&A up. And so we will take back some of these questions and work to update our public Q&A, which is on our website. We'll also communicate with Dr. Carroll and with Kitty to ensure that the information is out to the people on this call. We also will review any public comments that come in, and we have the option to make further changes to the regulation, but a decision on that has not been made at this time because, of course, the comment period is still open.
Okay, so we are gonna move to, we have a hand raised. Kirk Francis, we are gonna unmute your line for you to ask your question. Kirk, if you have your question, feel free to ask it. Otherwise, we'll move forward to any other questions in the Q&A box.
Hi, can you hear me now?
Yes, we can.
Sorry about that. So first of all, thank you for having the call. And my name is Kirk Francis. I serve as president of the United South and Eastern Tribes, as well as proudly as chief of the Penobscot Nation here in Maine. I think we all agree principally that patient protection of our staffs and communities are extremely important. Tribes from the very beginning have understood that with our populations being vulnerable and all those things, tribes have done an amazing job at trying to self-govern themselves through this process. And so I think a lot of the questions and frustration is around simply the self-determining decision-making of tribes in these processes. But again, I think we all understand the importance of everything in our toolkit to fight this pandemic. I don't want to be redundant. A lot of things have been asked, but I do think it's important for CMS to provide some real clarity, especially around these exemptions. If the facilities are going to be asked to develop the process and the path forward for those exemptions, we need to understand what the acceptable answers are in those exemptions. For example, if you look at the religious exemption, it talks in a lot of the materials that have been distributed about, well, if somebody claims a religious exemption, does this mean just for COVID-19, or were they ever vaccinated for anything else? So it appears that there's going to be an expectation of a detailed evaluation process in those requests. And also in terms of, if you could just expound for a second on, which seems pretty straightforward and clear, but has stirred a lot of debate within my tribe, and I'm sure elsewhere, on what the exemption is around 100% remote workers. So if you have a situation of an unvaccinated group of people in the healthcare system, does that exemption mean they simply get put on telehealth duties 100% of the time, and that cures and I know the goal here is not to avoid the mandate, but again, I think it just gets to my point of we're going to need some real clarity if we're going to be able to comprehensively, in some type of uniform way, address this issue. So thank you again for having the call, and appreciate any comments on that.
Thank you so much for your comments, and we greatly appreciate it. And as we said, we will take back some of the comments. With regard to the accommodations and as we state, the facility needs to determine what's in the best interest of the patients. And therefore, if you can isolate the exempted unvaccinated individuals, that is, and the facility puts that as their proposal, that's one option, but we recognize that may not be the option that leads to the best safety and care of the patients. So again, we will accept a plan. David, do you want to, any other comments that you or Lisa want to make?
Well, I was just going to add with regard to your comment about individuals who are 100% telework or 100% remote. Our intention was to acknowledge that there may be individuals who provide services to the healthcare facility, but never appear on site. So for example, a billing office that's off-site that does payroll for the facility. So while they have a contractual relationship with the facility, we would not require them to be vaccinated because they would not be coming in contact with patients or with individuals who take care of patients on a regular basis.
And I don't think I have anything other to add on with regard to exemptions in our review at this point.
We have another question in the Q&A box. When we look at the Medicare certification, we are under the FQHC, but we have multiple NPI numbers that are registered with Medicare. Our dental NPI is not included in the FQHC application for Medicare. Our providers are only referring providers. Are there any excluded from this rule, or are they included as a whole number, the health center? They are all in the same facility.
David, do you have any comments?
So we are surveying to the certified facility and whoever is employed within that facility. So I think, that would be our focus. Lisa, I don't know if and really don't appreciate fully whether the expectation is that we're looking at anyone under that roof, or would it be just the defined FQHC? My feeling would be we would stick to that defined FQHC that was certified, and not necessarily everything under the roof. Does that comport with your understanding?
Yes, unless the individuals who are under the roof have a relationship with the certified provider, some type of contractual or other agreement to provide services and care for the certified provider type.
Just a reminder to type those questions into the Q&A box at this time so we can answer your questions verbally. We have another question. Would construction contractors work in a health facility be held to this mandate?
If the facility is operating with patients, it is my understanding, and Lisa, it looks like you're shaking your head, that they would be held under this if it's a contractual obligation. If this is, certainly if they're not within the facility, within the patients, that would probably not fall within it. But certainly, I know in my own facility, there are always people working and fixing things. So is that your understanding, Lisa?
Yes, if they have a regular presence in the building and they would likely come in contact with healthcare workers or with patients, then the facility would need to ensure that they're vaccinated.
But if it was a once a year, somebody comes in to do an inspection of the HVACs, that would
Yes,
fall
that
within
would
the,
not.
would not.
No,
Okay.
that would not, correct.
That is great. That was my understanding, but I wanted to make that clear to all.
If you have any final questions, please put them into the Q&A box so we can answer them live. What if we are under contract for a current construction project and the contract was signed prior to this requirement?
If they're coming in to the facility where there are patients, then this would apply.
Tribal programs located within a IHS clinic would fall under this mandate also.
Does anybody have an answer?
I believe the answer is yes, to the extent that the general IHS facility follows the COPs.
We have remote workers in the revenue cycle that do come in 1 to 2 days a month, but are not in contract with contact with clinical staff. Are they exempt?
So the example of that would be if they actually worked in a separate building or a separate facility, that they don't come in contact with providers of care, then that would not fall within the COP. However, if they came into the building and met with the providers of care, then that would fall in within the requirement to have those individuals vaccinated. So it's either 1%, 100% telework, or that they don't interface.
Who is going to be held responsible for ensuring that contractors who have a regular presence in the clinic are or are not vaccinated?
That is the obligation of the facility.
Would you consider distributing a list of all tribal facilities by name and location that are covered by this healthcare provider mandate? Otherwise, prudent tribal administrators may have to spend valuable time confirming their facility is on or off the list of those facilities that are covered by this mandate.
Dr. Carroll or someone from the Indian Health Service, can they make a comment?
One of the issues that we find is we do not have at CMS a complete list of all tribal facilities. But we have been working with IHS to obtain that list in total. And I would hearken back to the rule that says that if you are certified by CMS, that the rule applies to you. And Leo, I'll look at you one more time and say, I think that's pretty clear. If you're certified by CMS, this rule applies to your facility.
And I'm just looking in the chat, and I just want to make sure we are not requiring patients to be vaccinated. That was a question asked. This is about employees of the facility.
And I will follow up with that question about facilities. We will have this recording available on our website as the webinar is processed. So it will be available within the next week or two. If you go to go.cms.gov/AIAN, and on the left side of the webpage, you'll see webinars and trainings, and under that section, this webinar will be available. And I think at this point, we are coming down to the last few questions. Michaela, if you could ask a couple more questions and then we can wrap it up.
Yes. If a tribal facility does not have a certification number, then it does not apply. If a tribal facility has a certification, then it does apply.
David, any comments?
Yeah, I mean, I think that's accurate. That's the CMS certification number is one of the ways that we identify who a certified provider is. So yes.
If we have a PTAN under 855A and 855B, does that mean we are certified?
I don't think it's a PTAN necessarily. I think it's more the CCN number. Again, it depends on what type of provider you are. And I would also go back to if you've ever received a on-site inspection to verify compliance with CMS requirements, that's a good indicator that you're certified under this requirement.
And I would like to say a PTAN number really signifies the ability to bill and does not reflect a certification. And I will have to check on that more critically, but I'm pretty sure that's the case.
I'll also just say the reason we don't have a list, we don't certify based on the type of the ownership, whether it's tribal or anything else. We certify individual providers based on the information that they submit through the Medicare administrative contractors. So we don't maintain a list of provider types by who's operating them. We maintain a list of all the nursing homes in the country or all the hospitals in the country. And that's what's available on our website, but we don't break it down by different ownership types, including tribal ownership. So that's why we don't ourselves have a list, because for us, what we're looking at is the individual certification, not the other information as to, again, who's owning or operating that facility in terms of our certification.
This is Dr. Carroll. I would like to thank everybody for spending time today with us with CCSQ. I want to thank Dr. Lee Fleischer for really fielding some very tough questions. And we all know it's a very sensitive rule that we are dealing with. I want to really impress everyone to submit your comments back to CMS regarding this rule in the very near future, if you can. And I would also like to recall that the CMS tribal consultation policy does allow for tribes to invoke consultation with CMS for further discussion on the rule that we're discussing today. We'll continue to look at the questions, have continued discussion. The CMS TTAG, Tribal Technical Advisory Group, will be having a call in December, and we'll be meeting face-to-face in March. And I'm sure there will be continued discussion, and we look forward to that. So we thank you again to CCSQ for holding this webinar. And I'd like to wish everyone a good afternoon, and thank you so much for attending.
Thank you for the opportunity. Thanks to my team. And again, we appreciate your comments and we will take them back.